Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Kevin Hopkins, a family medicine physician and physician director of health system engagement here at the AMA. Anyone who pursues a career in healthcare, especially as a physician, knows that the path won't be easy. If it were easy, anyone could do it. We know that the process of becoming a physician is hard, but I suspect that many physicians emerge from residency or fellowship training thinking that the toughest times are behind them. As a result, we may not be fully aware and adequately prepared for the challenges of the next 20, 30, or even 40 years of our career. Being a physician is one of the most personally rewarding careers a person can choose. Most of us have that innate desire to help people, to ease suffering, bring relief, to heal, to make a difference. Our altruistic tendency is to pour into others. But what happens when the well runs dry and we're trying to pour from an empty bucket? A career in medicine can be a grind, and many of us have doubts about our own ability to continue to do it for the long haul. I admit that I've done the mental calculations on how much longer I need to work in order to retire, probably hundreds of times. Dr. Jessi Gold is the inaugural Chief Wellness Officer for the University of Tennessee System and an associate professor in the Department of Psychiatry at the University of Tennessee Health Science Center. Dr. Gold works clinically as an outpatient psychiatrist and focuses her work on students, faculty, and healthcare workers. In October of 2024, Dr. Gold released her first book titled, How Do You Feel? One Doctor's Search for Humanity in Medicine. Jessi, thank you so much for being a guest on the podcast.
Thank you so much for having me.
Well, it's a pleasure. Before we dig into our topic for today, would you mind telling our listeners a little bit more about yourself and background than what I was able to cover in the intro?
Yeah, sure. I'll start with the human part because I think we always lead with our careers. So, I am the youngest of four. I have 7 nieces and nephews. I have a little dog. I like stupid television and I like Taylor Swift more than probably I should at my age. But I saw Taylor Swift open for Keith Urban when I was in college. So I've seen her every tour since. So that's my fun fact. Beyond that, I became interested in healthcare worker mental health starting when I was in college, honestly. I was an anthropology major and had to do a thesis and was watching all of my friends who I thought would be amazing doctors drop out of pre-med and kept wondering why we had those requirements and why that's what we were prioritizing. And it led me to doing my master's thesis in anthropology on pre-med as a culture. So I was very fascinated about that pretty early on, and that carried with me throughout med school, studying healthcare worker mental health from a med student perspective and access to care. And then when I actually was in psychiatry residency, I was able to run support groups for med students as a way of us learning group therapy. So we started a program where we learned group therapy, but we also got to support the med students. And so it's kind of been a thread for me all along pre-pandemic. And then, of course, the pandemic came and my clinical focus shifted to that and my administrative focus really shifted to that. And now I'm quite aligned in a lot of ways for what I'm doing clinically, where I see healthcare workers, trainees, and faculty and staff. And then in my job in Tennessee, where I'm based in Memphis and am in charge of wellness for a 5-school university system of about 62,000 students.
Wow, that's fantastic. And it sounds like you are as well prepared as anyone can be for your current career.
Yeah, it's like, sometimes you meet with students and they're like, how do I get there? Or what do I have to think about? And for me, I've always been like, I've said yes along the way where things were unexpected. I've never had a 10-year plan. If I had a 10-year plan, my job wouldn't have existed. And none of what happened during the pandemic would have informed my interests and what I did moving forward. I would have been pretty rigid in what I was doing. And so I've always been pretty flexible, but in so many ways, things have worked out in being like completely aligned fully with mission and things that I care about.
That's so cool. Thank you for sharing. I mentioned in the opening about your book, your memoir, How Do You Feel? One Doctor's Search for Humanity in Medicine. In that book, I know that you share your deeply personal experience of confronting your own stress and eventual burnout And I can't wait to sort of unpack some of your story and hear more about it. But first off, what inspired you to share your story and what your personal experience was like?
Yeah, I mean, I see healthcare workers as patients, and so often they say no one's ever experienced this. I'm alone in this. It's true outside of healthcare too, but there's this specific tinge of what people in healthcare say that shows that they weren't supposed to talk about it or it wasn't allowed to be talked about. And it feels like there was this like culture of silence. And so many of my patients say, that they kind of come as a last resort. Like, I haven't heard anyone yet. That's what they always say, which I feel like if a patient heard, they'd be terrified by that as their sort of bar for whether they showed up in my office. And, over the pandemic, I saw so many people saying that. And I was just like experiencing my own burnout at the same time and sort of in parallel going, well, I can tell you for sure that you're not alone because I'm experiencing it, but also so are all these other people. And why is it that we don't talk about this? And has there just maybe not been a way that feels tangible to folks? Like, I'm one of those people who run around and give wellness talks to hospital systems and different groups and stuff. And there's just this automatic, like, I'm going to hate this. They're going to tell me to fix me and not fix the system. I hate her already. It's just not, it gets through to some, but it's not the method to really get through to people. And I've always believed that stories change culture and that if they were in my shoes and sitting and listening to what I heard, they wouldn't feel alone anymore. And so putting it in one place and making it accessible and kind of thinking about all of the things that make it so hard to take care of ourselves when we take care of other people for a living was really important to me in that sense.
Yeah, wow, that's great. Thank you for sharing. Could you tell us a little bit about your story and sort of what your journey has been like and how you've developed certainly empathy for the people for whom you care directly?
Yeah, I mean, I'm not special in my story, which I think makes it even more interesting because I think if it was this very unique story that you would go, gosh, how did she get through that? You would be interested in it, but maybe less able to see yourself in it. And so I think in my sort of boringness of a story, I think it is more able to be applied to more people. And so for me, I was a psychiatrist seeing healthcare workers behind a computer screen for the beginning of the pandemic, had never seen a patient telehealth before, had really been, learning so much in person. And I loved that connection to patients as part of why I went into psychiatry. I also was very much an extrovert. And when we were told basically after spring break to not come back into work, we were sent home. And in that setting, sort of every place that I was getting energy changed. As a psychiatrist who, went through med training like everyone, I also had a weird amount of guilt not being a frontline worker. Like, I wasn't on the front lines despite being a person holding up the front lines in their mental health. I felt very much like I'm supposed to be there. That's what I do. But at the same time, didn't really think I had the skills to be there. So in order to kind of make up for my guilt, took on more of an administrative role by voluntolding myself into it. So I wrote my chairman and was like, what are we doing for the mental health of the healthcare workers? And he said, what are we doing, Jessi? Write a plan. So I wrote a plan, which led to a leadership role for me eventually, but made it so during the pandemic, I wasn't just seeing patients. I was doing like these drop-in sessions and conversations and talks about these topics as if they were easy. So I was pretty much like nonstop doing as much as I possibly could because of that guilt, but this desire to be helping as much as possible in this setting. And I didn't pay attention to myself at all in that context because I didn't think about it. It didn't seem to resonate. There was no reason to. And I really didn't pay attention to myself until I had no choice. And for me, that was two things. One, I was falling asleep every day after work. Like, I would go to my couch, put on a TV show, and wake up 4 hours later. And I didn't even know I went to sleep. And it was that kind of fatigue where you actually feel like you have COVID, like your whole body is just achy and you don't know how you fell asleep. And that was making me concerned. And then at the same time, there's a story that I lead off with in the book where I won't go into too many details, but I forget a patient and that I'd met them before. And I've had other doctors say I do that all the time, Jessi. And I think there's a truth to that. But for me, as a psychiatrist, it's not really acceptable to not remember someone's story when they haven't told anyone it before. And even if that meant I looked at a chart to remind me, as every one of us does, I didn't even have the ability to have done that. I wasn't pre-planning enough. I wasn't organized enough. I didn't even do the things that would have prevented this from happening logistically, right? And then I felt very much like I hurt someone by not remembering them. And that was just not the kind of medicine I wanted to practice. And, I luckily didn't make a mistake that was irreversible, and luckily didn't make a mistake that wasn't something that I could fix with that patient over time. But it really affected me and how I kind of conceptualize myself as a clinician. And so that fatigue plus that really led me to start investigating what was wrong with me. I'd love to tell you that immediately I knew I had burnout, because all I do all day is talk about burnout, but I didn't. I had to go a lot of different routes to figure that out, and ultimately have someone else tell me that's what was going on. And I think for me, in telling that story and my experience, I want to highlight how almost pervasive and subtle the experiences of burnout are, where we can, as a culture, sort of look around and see other people who look like we do, but that is burnt out. But we assume that's just a side effect of our job, and we're all supposed to feel and look like that. And so we don't say anything. We also all have this sort of if it's not interfering with work, I can keep doing work and I'm going to go to work. And that's how I felt until it really did interfere with work. And I also think we know things that we specialize in, and we don't. We're not as good at being our own doctors for a reason. There's a reason we can't see family members. And I would have told you that, of course, I would have been able to identify burnout in myself because I can rattle it off so easy, but I couldn't, which to me also gave me further empathy for my patients who can't, because I know the definitions and the signs and symptoms and everything, all front ways and back ways. And they probably have never even heard of them for some of them. And how could they identify it if I couldn't?
Yeah. Wow. You said so many things in there that were so powerful, and I didn't pay attention to myself at all. And I think that a lot of us are probably very guilty of that, whether we want to admit it or not. And also the point about just the fatigue and exhaustion and really eventual burnout being so pervasive and subtle that I think we all have probably normalized it. I know, especially coming through COVID, you kind of looked around and you saw the same look on everybody's faces, and yeah, we're just all exhausted, probably burned out. Well, this is what it is to work in healthcare in 2020, 2021, but now it's 2025. And are we still normalizing that? And so I think that's a really powerful observation for you to share.
Yeah, it's unfortunate that even though we're trying to move towards being more well, we still have a culture that isn't. I think that leads to a lot of tension between younger folks and older folks about what it means to do our job. But I also think there's a middle ground that is it's a bit healthier, and we could have a healthier profession where we care for other people and ourselves without all the arguing. And we're just not there yet either.
Yeah. Right. For you specifically, Jessi, was that patient encounter, was that the turning point that really made you realize that you needed to prioritize your own well-being?
Yes. I mean, that, and I just wasn't getting better with the fatigue. There was nothing happening and it wasn't going away. And then it was ruining my sleeping at night, and I was becoming harder to do what I needed to do. And I could feel myself about to fall asleep at work, and that's not great either. So it's, forgetting something or falling asleep, one of the two was going to be the problem. And this isn't who I want to be. I think I kept telling my therapist, 80% of me is better than none of me because you don't have access to me. And I don't think I was at 80%, first of all. And then, second of all, what does that even mean? It was a weird way of rationalizing why I could still go to work when I felt so crummy. And, I hear that so much from patients, and our bar to skip work is, are we actively hemorrhaging? Did we need to be hospitalized today? Otherwise come in. And any sort of mental health related thing doesn't really ever cross the line in that sense, because we don't hemorrhage. It's internal. You can't see it. And so it's really hard to take time off for that stuff when we feel like we don't even want to tell people why that is. I also realize that every time I take time off work, I'm like, this is what I'm doing. Just in case you're wondering, this is what I'm doing. And my therapist said to me once, like, does anyone else tell you where they are? And I thought about it and I realized, like, no, that I had no idea where people were when they weren't at work, that it was my own sort of desire to prove that I earned the vacation or that I was sick enough to be home. Like, I would write really like detailed emails about what was wrong with me physically. They didn't really care. It should have just been my choice. But there's just like this desire to not be seen as somebody who's using that willy-nilly, and also to be seen as someone who's reliable and shows up and cares. And I think all of that can be true, and we have to care for ourselves at the same time.
Yeah. So really interesting. Why do you think we are the way we are? Why do we feel like we've got to push through everything, even if it's something that we can't possibly push through? Is it pride? Is it inability to admit weakness or to ask or accept for help? Do you think it's our just personality, or is it part of our training? Yeah, it's probably all those, but what do you think?
I think it's a lot of things, but I think that that the culture in training really changes our beliefs about what we're allowed to do and not do in our profession. That really early on in training, I mean, med school even, you can't really ask to go to the bathroom on rotations. You can't really eat. You're shoving your pockets with granola bars. That's part of prepping you for third year, is like, did you bring granola bars in your pocket? And we learn really early to ignore like physical cues like that. And it's modeled for us. I remember when I was in med school, one of the surgical residents like passed out in a case, but then like didn't hit the field at all and stepped back and ate a banana and came right back in. And everybody was like, yeah, she didn't even mess up the field when she went down. Look, she only went out for 2 minutes, whatever it was. And I remember being like, that's a little strange, but also I guess that's what I'm trying to be, right? And so you get it modeled, and then people are getting praised for it, right? Like your co-residents or your med students or residents when you're a med student, and you see like, I'm getting evaluated poorly because I needed some time for me, but maybe somebody else gets like higher marks or subjective evaluations for being there all the time and not caring about themselves in the equation, or being more stoic. And they use things like, you don't have good boundaries if you like go back to a patient and want to sit and talk to them, and you're like, but I just wanted to talk. Like, sometimes you just need to talk to them. Like, it isn't always about the diagnosis. And so I think there are explicit cues, but also implicit cues that we get really early on in medicine, and we learn to be successful, to be the best, to be like in a competitive field like we are. Your needs are last. And in fact, it's maybe narcissistic and selfish and wrong and boundary breaking if you put your needs in the equation at all. And it took me a long time to realize that that had seeped into my head. Like, I think there were times in med school where I was like, that's stupid. Like, why would anyone act like that? No one would ever do that. And then you catch yourself doing it, even though you were like, that would never be me. And it's just weird how much that culture just creates a specific model of what's valued and what matters.
So, in your experience, because your practice focuses a lot on taking care of healthcare workers, does there still exist hesitancy, especially for physicians, to seek mental health support due to the stigma associated with it, and also to the fear of professional consequences?
Absolutely. I wish it wasn't true. And I think there have been people trying to make that better by changing licensing state to state and advocating for that. And the Dr. Lorna Breen Heroes Foundation among those, but other people have been doing it state to state through state advocacy. The AMA does that as well. That helps tangibly make it so we can get help and then not worry about losing our license, because that's illegal anyway. But the lore is still there. The cultural conversation around it is still there. And you don't really see people going to get mental health help or talking about it really openly. And there's a study where they asked med students when they came in, basically like, did you think mental health was health? And, is there a stigma associated with it? It was very small numbers that agreed or strongly agreed. But then they said basically they think their peers would care, that their residencies would care, their supervisors would care, and their patients would care. And as a result, when they asked them at the end, like sort of, would you tell someone if you got help? Those numbers were overwhelmingly like, no. And I think we have that culture of silence, and that just perpetuates itself, right? So if like we are getting help, but we don't talk about it, we think no one's getting help, we're not supposed to get help. And so that creates stigma. I think we see mental health patients get stigmatized with sort of offhand dark humor and comments in the emergency room. For example, psychiatrists have done it, I'm sure too. It's not just emergency room doctors, but it is like there's like sort of a flippant thing that sometimes happens with patients who are struggling with their mental health. And then you say, well, I don't want to be labeled as that. And that kind of seeps in too. And it leads to people not coming. I mean, I think a lot of people wait to come until they're pretty sick, in part for the reasons I mentioned, where we don't even recognize it, but also because of stigma. And then that can also lead to us not coming at all. And we have high rates of suicide in our profession. And so the stigma plays a big role, even though we understand mental health from a biological perspective and we learn about it in school, and we shouldn't have stigma. If anybody shouldn't have stigma, but we do, because I think we think doctors are supposed to be invincible and not struggle. I mean, I recognize that I spend all day prescribing meds to other people and that I stigmatized myself for being on meds. And I thought that was the weirdest thing, because it didn't make any sense, because I'm very authentic and very much exactly what I'm saying I believe. But deep down in my head, I was filtering out, like when I talked publicly about my mental health, that I was on meds. And I talked to my therapist about it and really realized that I had that same thing. Like if my colleagues knew I took mental health medication, they would. And I said, like, judge me, think that anytime I had emotions, I was going to crack, that I was much more sick at one point than I was now, that I shouldn't be a doctor. I said, like, I was worried my patients would care. And I heard myself say that and was like, what? Like, I don't even know how that like is in there. I spend all day prescribing to people exactly like me, telling them that an antidepressant is the same as a blood pressure medication. And yet here I am for myself not applying it once again. Like, so I think it's more pervasive than people even realize. I think if you asked a bunch of people if they stigmatized mental health, they would say no. But when it came to themselves, they still wouldn't get help. I was much more likely over the pandemic to see people's dependents than I was to see them. And sometimes their dependent liking me and having a decent experience could lead them to come in, but it's definitely there and it's sad. And sometimes people don't talk to me in hallways because they're like afraid people will think I'm their patient. And like, I'm in administration. Like, there's so many ways that you could know me that's not that you're my patient. And it's just so interesting because those same people are totally fine walking right up to the person who delivered their baby and giving them a hug. But it's like terrifying that the other, like that I might know your emotional secrets, not like everything going on with your body, right?
You're absolutely right. It's somehow different when it's me we're talking about, and it's not you or them or some other people. It's different when it's me for some reason. How do you think, or are there ways that you've discovered to help create, build, even within an established practice or physician group? How do you encourage the culture where seeking help is normalized and not just like permitted, but encouraged?
It really starts with vulnerability in the workplace and feeling like your workplace is a safe place to even have a conversation like that. It doesn't mean, like, when I say vulnerability, I don't mean that everyone has to do what I've done on this podcast, which is like talk about my own burnout and meds and stuff. Like, I had to work myself up to that. And I believe that like me doing that will make it easier for other people to do the small things. And I think that's what matters. Like, I don't think we need a million people doing what I do. I wish someday that what I do would be boring, but we're not there yet. I think that we have to say some of the quiet stuff out loud and we'll feel less alone. So when I talk about vulnerability, I mean, if you see a code and you're going to go eat lunch right after, maybe say, it's really weird we're going to eat lunch right now, as opposed to just assuming that it's totally normal that you either saw a successful or unsuccessful code and then went and ate. Like, that's not normal. Or, you're having a hard day because you're tired and you have a newborn baby. Maybe say, I'm a little snippy today because I didn't sleep well last night because of the baby. That tells the person that's with you that you are a human who has a kid who sometimes doesn't sleep. And then if they're at all struggling, they'll say, oh, that person told me they sometimes don't sleep and that they struggle with work-life balance. And it opens the door just a little. And like that opening of the door just a little will make it so, maybe they'll test it out. But when they really want help, they'll know they can do it because the door's already cracked. It's not like completely shut or scary. And so I really believe in little moments of vulnerability in the workplace. I also really believe in transparency in the workplace, which to me is like systems vulnerability, because people hate people who do jobs like mine because they think that they're just sitting there doing nothing. And some of the time maybe we are, but I'm not. And I think that the belief about that comes from nobody knows all the roadblocks you're hitting and nobody knows what you're doing behind the scenes. And I think there's just like this Fight Club mentality to everything in medicine, but there's so many steps to everything. I mean, the AMA, like passing a resolution is 100 steps, right? Like, if you've never done that, you would have no idea that these things take so much time and energy to really do sometimes the smallest things, but can make a big difference. And so I'm a big fan of, like, as much as possible, explaining that to your employees and the folks that you supervise, like help them understand systems and the barriers and the things that you think are stupid too, but you have to do them. Like, you don't like Epic. Just say you don't, like, I don't know why we have to be in this pretend zone of we love all of this stuff. It's just you who's struggling. I think it's helpful to be like, EMRs have pluses and they have minuses. And for me, like today, it has a minus because I'm struggling with this. And it just normalizes the fact that, like, you don't think the system is perfect and you don't think the system doesn't need changing. But at the same time, some of that stuff might not change. And we need to be open to the fact that that's what our workplace looks like right now. And we have to have transparent conversations about what's possible and what's not possible and why. And I hear so often from people like residency directors who say, like, well, I wish I could give that person that day off, but I can't. And because of all these reasons. And I was like, well, did you ever tell them all those reasons? Because I think that they just think you're being a jerk who doesn't want to give them the day off. And like, explain scheduling, explain how we don't have a lot of redundancy and that's a fault of the system. Explain how residency program numbers are set by the government. Whatever you want to explain that could help you feel like there are reasons behind your decision, which you too agree is sad and frustrating. Like, say that out loud, because when I was a resident, if somebody would have said things like that, like, listen, I wish I could give you the day off, but X, Y, or Z, it's really stupid. That's how it's set up. Unfortunately, my hands are tied. I wish I could change it. I hear you. I'm sorry. I would have been like, oh, well, guess I'm not getting the day off, but I also don't now hate the program for it. And there's just a lot that can come from open and honest, transparent conversations about this stuff.
People who know me really well know that I often let things that should stay inside my head out of my mouth. But what I'm hearing you say is that sometimes it can be helpful for us to release that inner monologue a little bit, and just small bits of transparency and vulnerability that, let the people around us know that we are human and that we do see what's going on and that we do think that it's strange or odd or awkward. And even your example of, giving people reasons why we have to make a certain decision as maybe a leader or health system, we assume that people know the reasons, but they don't. It's not so safe to assume that, right?
No, it's not. And for the most part, the reasons are complicated and hard to even understand as a leader, right? Like, sometimes
Yeah.
when you're in system roles, you go, well, why can't I do this thing? I don't understand. I have to ask 17 more people to do this thing. And even as a system leader, it's frustrating. And I think when you have never been in leadership and you don't understand all the systems at play, and medicine is a field of intersecting complex systems. Like, point to one that's not: insurance, government, medicine, hospital systems, pharmaceuticals, I don't know, residency training, all those people. There's all like laws and rules and things for all of them, and they all intersect in ways that are mostly immovable. And I don't know that as a young student or trainee or even young faculty, you've really been exposed to enough to be able to understand that people aren't just sticking it to you to stick it to you. And I think that that would make the practice of medicine feel like we were on our sides, even if we don't feel like the system is always on our side. Like, it it's hard to feel like medicine understands us sometimes, but we really do need to be able to support and understand each other, because I'd like all of us to stay in medicine and not quit. And we need doctors and we need nurses and we need us to be doing this, and we need good people to not just be like, I don't want to do this anymore because the system doesn't understand me as a human. We need to mold to better support our, like, all of us as humans.
But Jessi, in your book, How Do You Feel? You also chronicle a journey of four other healthcare workers, professionals, pre-professionals. And what is it like sort of being in a clinical practice of psychiatry, where you really specialize in helping to take care of caregivers? And what have you learned about having a career in healthcare as you've done that?
I love doing that. I don't know that I ever woke up and said like that was a clear specialty, because it wasn't a clear specialty until it became one. I think we're not necessarily treated like a separate culture. Like, therapists get training in working with police and working with emergency vehicles and people who work in EMS, but they don't get that in healthcare. And there's something special to go see someone who's been through it, who understands, who's not going to just tell you to go to sleep, who understands that medication management might have to be around shifts, who gets why you're afraid to be there in the first place and tries to support you through it. And I feel that practice has helped me understand medicine and the things people want from it in ways that I didn't before. It's probably helped me understand myself in a lot of ways too, because somewhat selfishly, a lot of my patients are quite similar to me. And you can learn a lot that way from the similarities and the differences. I think as a system leader, I had a lot of conversations around like, do I still want to see patients? And my answer was always like a resounding yes. Like, I don't want to be full-time patient care and full-time administrator. That doesn't work. But having a foot in what people are experiencing day to day and being able to support them through it is where I get meaning, but also it informs the broader systems work, because you can see where the frustration's coming from, where the burnout's coming from, where the faults are that need fixing to then help a person in a different way outside of medication and therapy in your office. And, I think it's a very powerful way to learn about a group and what they're struggling with. And I felt privileged to be able to do that. And I think uniquely positioned in an administrative role to be able to help. Not a lot of folks who do roles like mine are mental health providers, but on top of that are not ones that exclusively see healthcare workers. And so I have a very aligned clinical practice with everything else I'm doing. And I think that informs what I do in ways that I probably don't even realize, but probably makes me a better advocate still for the folks on the ground, because I'm just less disconnected.
So part of the emotional toll of being an empathetic physician is our tendency to not allow ourselves adequate time to disconnect, to recharge, to relax, to recover. And so we're always on and never really removed or disconnected from active patient care. What are some ways that you encourage physicians to support themselves to do that?
I'm going to first off vulnerably just say, like, this is a work in progress for me too. I think that all of us, this is a work in progress. There'll be times where I'll be saying something and my therapist will say, I'm pretty sure I know someone who wrote a book about that. And I get it completely. But, it's like, it's one of these things that we're training out of ourselves. So some of the things that made us successful to get where we are the things that don't let us shut off, because we're kind of constantly competing and also constantly putting others before ourselves, because that sort of was part of what drew us to the field in the first place. And so we have to like actively work to change that. It's not a passive thing. We can't just be like, today I will no longer do work at home. Like that won't happen. And so it's things like recognizing where you can put boundaries that feel good. It's things like scheduling in time for yourself and holding yourself to it. It's things like turning off notifications, even if your email's still on your phone, but just making sure it's not going off constantly. It's things like I talked to someone who puts the phone out of, like, they come home and they put the phone in a basket and they go look at it in an hour, and at least give that hour to someone else, as long as you're not on call, right? And being aware that there is probably someone else that can do what you're doing, especially if you're not on call, that what you're doing in your off time makes you better at what you're doing in your on time. I think it's often been framed like it's taking away, but it really is giving back, right? So if you're burnt out, your colleagues are more likely to be burnt out. You're not helping them. If you're burnt out, you're more likely to make errors, have lower patient satisfaction, et cetera. And all of that is true, but our justification is like, I have to show up to help patients. Well, you're not helping patients by showing up when you're like that. And so it's important to reframe that for us. I think it's important to recognize that these are things we have to get out of our head. And sometimes that requires therapy. Sometimes that requires coaching. Sometimes that's just an active practice, right? Something like self-compassion is something all of us need to work on. You could get a book and you could work through it yourself, or you could work through it with someone else. But these are big topics that we often have to work on in our jobs: boundaries, self-compassion, recognizing the good in a day, even if we had some bad, not in a toxic positivity way, but in a, okay, both things can be true, and those things are all really necessary. And there will be times where we say yes to too many things and we kind of go, up, there I go again. But at least you recognize it, and at least you know how to get yourself out of it. And the most simple thing, honestly, and why it's the title of the book and why it's what I've worked on, is like, I had never stopped and asked myself how I was doing. Like, not once. It seems so silly. Like, why would I do that? But, if you're just going patient, 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 talk, 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 patient meeting, patient, and never going like, okay, like, I need a second for me. What's that feel like? How am I doing? You never do it until it bubbles up, and that is much worse when that happens. And so just as simple as recognizing yourself in the equation and trying to ground yourself in the conversations that you're having and the work that you're doing as a person in the room, and not a robot or a dissociating person, whatever you think you actually do, is really important.
What do you hope people who read or hear your story and your experience, what do you hope people will take away from it?
From the healthcare side, I hope people know they're not alone, and that a lot of us are dealing with this and they don't need to be dealing with it in silence. I hope they take a step towards having these conversations with each other a little bit more, whether the book helps prompt it in a book club or something, which is partially why that can be helpful, or whether it's just you read it and you had some thoughts and you wanted to talk about it with someone. Like, giving yourself space to take the step to sort of attempt to change our culture a little bit. I hope people do. From a not healthcare perspective, from other folks, I hope people recognize that, caregivers are caregivers, and all of us experience similar things, and you'll resonate with a lot of the same things, I think. But also that sometimes when a healthcare worker is not spending as much time with you, or seems more frustrated, or is having a hard day, maybe it's not about you. Maybe it's about something else. And maybe if you said thank you even one time, it would be the best thing that happened to them all day. I have a box of things that patients have given me over the years as thank yous, which is tiny and not full of a lot, because I'm a psychiatrist and I think people think it's like boundary breaking to do something like that. But it is where I go when I'm having a hard day. And I know I'm not the only one. It's where I find meaning. And patients have a lot of ability to do that for us in ways that I don't even think they recognize. It's not in spite of their own pain and in spite of their own suffering and stuff that they're dealing with. But it's just a sort of recognition that we're also a human in the room with them, and that a lot of the things that frustrate them probably frustrate us too. And the person answering the phone did not do all of the things that are making you mad, and whatever it is, just sort of having a step back to recognize that, and how hard sometimes our job is, even if we don't say it or have been conditioned not to, I think would be important from an outside perspective.
Great. Thank you for sharing that. Dr. Jessi Gold, Chief Wellness Officer for the University of Tennessee System, has been our guest. Thank you, Jessi, really for your willingness to be vulnerable and authentic and to share your personal experience and what you've learned as a result of what was probably a very difficult time in your life. And I just appreciate your willingness and ability to open up and share that experience with our listeners. For our listeners, please check out the episode description to explore resources associated with this episode. And until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.